arterial physiological assessment and arterial duplex scan. Little bit of introduction. Peripheral arterial disease can be usually diagnosed by careful history and physical examination. The arterial physiological testing adds a degree of objectivity to the subjective clinical evaluation. These tests are useful in determining the extent to which the arterial disease limits the walking in patients who may have concomitant orthopedic or neurological problems contributing to their disability. Non-invasive tests can be used to detect peripheral arterial disease in an otherwise asymptomatic patient, which is significant because peripheral arterial disease is an independent risk factor for cardiac events. These tests are uniquely able to identify intermittent arterial obstructions, such as those arising from entrapment syndromes, and to distinguish between fixed arterial obstruction and obstruction due to vasospasm. In patients with advanced disease, physiological testing helps to determine the ability of ischemic ulcers to heal or provide a guidance to optimal level of amputation. There are three types of information that these investigations tell us. One is an anatomic, then hemodynamic, and functional. Anatomic, in which it tells us the arterial segment that is involved, the type of lesion, whether stenotic or occlusive, the morphology of the lesion, thrombosis or atherosclerosis. Hemodynamically, they tell us the severity of obstruction, and functionality-wise, they tell us about the severity of impairment of limb function due to the lesions. Indications for arterial physiological testing, as they were established in the Journal of Echocardiography in 2006, were exercise-related limb pain, that is claudication, limb pain at rest, extremity gangrene or ulcer, assessment of healing potential, absent peripheral pulses, digital cyanosis, cold sensitivity, arterial trauma or aneurysms, and an abnormal ABI. Modalities of arterial physiological assessment are ankle brachial index or toe brachial index, segmental pressure measurement, plethysmography, transcutaneous partial pressure of oxygen, handheld Doppler, laser Doppler, duplex scanning, and direct pressure measurement. Talking about the first one, a Doppler ultrasound. The Doppler ultrasound device compares the frequency of backscattered sound from a moving red blood cell with the transmitting frequency to determine the frequency shift, which is proportional to the speed of the flowing blood, the transmitting frequency, and the cosine of the Doppler angle, that is theta. The principle of a Doppler ultrasound is that it's a handheld continuous Doppler with a frequency ranging between 5 and 10 megahertz. It has limited penetration, hence it is suitable for more superficial arteries. The tip of the probe has transmitting piezoelectric crystals that convert the electrical energy to ultrasound waves. It also has a receiving piezoelectric crystal that detects the reflected ultrasound wave. The probe converts the detected frequency shift and sends it to the speakers for an audible signal. There is a fluid interface, which is generally an aqueous gel, that is required between the probe and the skin to allow penetration of the ultrasound waves into the tissue without significant loss of energy from impedance mismatch, which is the difference in density causing significant reflection of the ultrasound wave, thus preventing further tissue penetration. The Doppler ultrasound is based on the Doppler effect, which is in it, the transducer emits an ultrasound reflected from the RBC. If the RBC, that is the flow of the blood, is towards the transducer, the frequency of the reflected sound wave increases, while vice versa when it is flowing away from the transducer. That is, there is a decrease in the wavelength of the sound that is reflected. The oral interpretation of this Doppler waveform is that a velocity of the blood flow is proportional to the frequency shift, which is heard as a change in the pitch of the audio signal. The loudness is proportional to the volume of the RBCs moving through the Doppler signal path, and a turbulence due to obstruction or stenosis causes non-uniform velocities and imparts a harsh quality audible Doppler signal, resulting in a noisy high-pitched signal at the site of the stenosis. A normal peripheral artery at rest has a triphasic or a biphasic quality of wave. It has a brisk upstroke due to forward flow in the systole, then a sharp downfall due to reversal, due to the reversal of flow due to high resistance on the periphery. And finally, there's a small forward diastolic flow component, which may or may not be in all the peripheral arteries. This is a normal biphasic and triphasic velocity waveform. Then we have a monophasic velocity waveform that occurs when the peripheral vascular resistance is low, either due to arterial bed downstream, such as in the kidneys, brain, or liver, or after exercise, in which hyperemia or intravascular administration of vasodilation, the velocity waveform loses the reversal of the flow component and becomes monophasic. From the forward flow throughout the cardiac cycle. This occurs normally when it is in areas where it should be biphasic or triphasic. In that areas, when it becomes monophasic, it is an abnormal waveform. The clinical application of a handheld Doppler is it is used in calculating the ankle brachial pressure index. It is used in segmental pressure measurement. It is used in calculating the Profunda-Popliteal Collateral Index, PPCI. It is used in the penile brachial index and in stress test. The first one, the ankle brachial pressure index. In this, the cuff is placed as low as possible on the leg above the ankle and inflated above the systolic pressure, and then slowly deflated while the Doppler probe is held at the PTA, which is just behind the medial malleolus, or the DPA, which is slightly lateral to the extensor hallux longus tendon, approximately a centimeter distal to the ankle joint. If the ankle pressure is recorded as the highest pressure at which the Doppler signal returns. If no signal is obtained at the DP or PTA, we should check in the terminal branch of the peroneal, that is the lateral tarsal artery, which is anterior and medial to the lateral malleolus. However, in this artery, the pressure may not be as good a measure of the pedal flow as it is in the other two tibial arteries, because it does not directly connect to the pedal arch. The ankle brachial pressure index is a ratio between the systolic blood pressure at the ankle and the highest of the two upper extremity pressures. So if you're calculating the right ABI, then it is right ankle pressure divided by the higher arm pressure, either right or left. Similarly for the left. The normal ABI is 1 to 1.29, 0.91 to 0.99 is considered as borderline or equivocal, 0.4 to 0.9 is mild to moderate PAD, while less than 0.4 is considered severe peripheral arterial disease. ABI has a role in screening, diagnosis, prognosis, and follow-up. It has a sensitivity of around 80 to 95% with a specificity of 95 to 100%. A false ABPI can be recorded due to improper patient positioning. That is, if the patient is in standing or sitting or a semi-recumbent position, or if the patient has got less than 10 minutes of bed rest, or in a wheelchair-bound patient. A faulty cuff can also give a faulty ABPI. So therefore, the recommendation is to keep the bladder cuff of 80% length and 40% width of the circumference of the extremity, a ratio of 2:1. A stiffened artery can also give an abnormal ABPI, which occurs in medial calcinosis due to diabetes mellitus or chronic kidney disease. Increased artery pressure is, in this case, increased pressure is required to collapse the arterial wall and stop flow of the blood. And ABI may be, in this case, may be more than 1.3, or it may be non-compressible. The artery may be non-compressible. In case of unilateral or bilateral upper limb peripheral arterial disease, you can in this case also you can get an abnormal ABI, a faulty ABI. In this case, it may also record upper limb pressure may be even lesser than the lower limb pressure. Coming to segmental pressures, ABI cannot. An ABI can be a good screening test for arterial disease, but it cannot assess the level of the arterial stenosis or lesion, which can be done with segmental pressures. The method for segmental pressure measurement is you make the patient lie down supine for about 20 minutes. Then pneumatic cuffs are tied at thigh, calf, and above ankle level. A resting ABI is calculated and the pressure is gradually increased in each of the cuff to 20 to 30 millimeters of mercury above the systolic pressure. The segmental systolic pressure is recorded between the two adjacent cuffs using a handheld Doppler. Interpretation wise, if the vertical pressure difference between two cuffs is more than 20 millimeters of mercury, it signifies a significant occlusive disease. It is similar between the two legs also. If at the same level there is a more than 20 difference between two cuffs in both the legs, then it signifies a significant occlusive disease on the side which has the lower pressure. Advantages of this segmental measurement is that it gives an idea about the possible level of the disease and can also be used to estimate the Profunda-Popliteal Collateral Index. I'll be coming to that next. But the disadvantage is that the distalmost cuff is at the level of the ankle. So below this level, if there is a disease, we cannot know of it. It does not give the exact anatomical detail. It may cause patient discomfort, and it cannot detect disease in the non-axial vessels like in the profunda. Coming to Profunda-Popliteal Collateral Index, it estimates the extent of collateralization around the knee. It is useful in patients with SFA occlusion, and it is calculated as the above knee pressure minus below knee pressure divided by above knee pressure. A low index indicates good collateral development, that is, there is a little pressure drop across the knee, while a Profunda-Popliteal Collateral Index of 0.2 less than 0.25 is suggestive of a good result. It is predictive of a good result from a profundoplasty without an intrainguinal bypass. But if a PPCI is more than 0.5, it is a prediction that there may not be any improvement with only a profundoplasty alone, and an intrainguinal bypass is necessary. The next is toe brachial index. The digital arteries are less commonly calcified than the tibial arteries. Hence, toe pressures are most useful in patients with arterial calcification, like in patients of diabetes or in patients with CKD. It is sensitive to disease at the level of the pedal arch and digital vessels, which is not detected by ankle pressure measurement. Even digital arteries can be calcified and non-compressible, at which point, if that happens, then the next best assessment is made by a TCPO2, which is transcutaneous oxygen tension. A normal toe pressure is between 20 to 40 millimeters of mercury less than the ankle pressure. Pressure less than 30 millimeters of mercury is considered abnormal, while a TBI less than 0.7 is considered abnormal or is suggestive of a chronic limb threatening ischemia. Interpretation and limitation of this is a correlation between foot wound healing and toe pressure has been shown, and unfortunately, toe pressures often cannot be obtained in patients with forefoot or digital gangrene for whom transmetatarsal amputation is contemplated. As you can see in the figure, this is a probability of healing of a wound or minor amputation in relation to the ankle blood pressure. Toe blood pressure and transcutaneous oxygen tension. Coming to plethysmography, plethysmography is based on measurement of change in volume of the extremity caused by cyclic nature of arterial inflow. Change in volume causes a change in circumference and therefore in the length and electrical resistance of a strain gauge. The resistance is easily measured and plotted on a strip chart, which results in a waveform that has the same basic contour as a pressure wave. And there are two types of plethysmography. There is an air plethysmography and an impedance plethysmography. Air plethysmography monitors the pressure in a cuff placed around the extremity and inflated to 65 millimeters of mercury because the cuffs are more rugged and easier to use. In impedance plethysmography, it monitors electrical impulse, which is inversely proportional to the volume. The resistance is measured and plotted on a strip chart, which results in a waveform or a pulse volume, a PVR, pulse volume recording. Pulse volume recording waveforms are obtained at various levels of the lower extremity and can be used to infer the presence and location of an arterial occlusive disease. A pulse volume recording thus shows three types of waveforms. It shows a rapid upstroke. A normal pulse contour has a rapid upstroke, a sharp systolic peak, a diacrotic notch, and a downslope that bows down towards the baseline. When you have a stenotic lesion, the waveform below the stenotic lesion is as shown in the second figure. It has a slow rise time. It has a flattened peak. It has an absent there is no diacrotic notch, and you lose the it is concave down instead of being concave up. Thus, a decrease in a pulsatility from one segment to the next indicates the presence of a stenosis upstream. The extent of the change in the waveform is related to the severity and the extent of the proximal disease. Similar waveform changes may also be caused by downstream disease, which may confound the results. A normal volume plethysmography, as the first one is a normal one, which shows the rapid sharp upstroke, a scoop or a flat line between the peaks and a possible diacrotic notch. When there is a mild abnormality, there is a sharp upstroke with no flat period or a scooping between the peaks and no diacrotic notch. In a moderately abnormal blood vessel, there is a flat peak, equal upslope and downslope time, and no diacrotic notch. In a severely abnormal blood vessel, there is a flat peak, equal upslope or downslope, no diacrotic notch, and low amplitude waveform. Advantages of a PVR are: a PVR is less affected by than pressure measurements by arterial calcification. The combination of segmental pressure measurements and PVR is more accurate than when either of the methods are used alone in detecting a PAD. They require less technological expertise. They allow assessment of the adequacy of the collateral circulation, and they are appropriate for screening purpose. Coming to digital plethysmography, it is more useful when calcification of the tibial artery causes a false elevation in the ankle pressure, or when a patient has an occlusive disease distal to the ankle level. Digital PPG probe sends an infrared signal into the tissue and has a detector for backscatter light that corresponds to the variation in the blood volume over time. A pulse oximeter is a form of a PPG probe. It is useful in determining the extent of sympathetic activity in patients with cold sensitivity, and it is useful in determining Steele syndrome caused by dialysis access grafts. The pulse contour in the digits is similar to that described for a lower extremity. It also has a normal waveform like a rapid up slope, a sharp systolic peak, a diacrotic notch, and a downslope that bows towards the baseline, just like the PVR waveform. Occlusive disease cause dampening of the waveform with flattening or loss of diacrotic notch. In extreme cases, there may be no detectable waveforms. Conversely, the presence of a abnormal digital waveform indicates that there is no clinically significant arterial disease in the arteries supplying the digits. Reactive hyperemia. This is another form of non-invasive laboratory investigation. In this, a cuff is placed at the ankle or above and inflated above the systolic pressure for 3 to 5 minutes and then rapidly deflated while the digital PVR is monitored. It is useful for predicting response to sympathectomy. In a normal limb, the pulse waveforms rapidly attains half its baseline amplitude within a few seconds and then rises quickly to twice its baseline. In peripheral arterial disease, as you can see in the figure B, the reappearance of the waveform and return to half the resting value is markedly delayed in proportion to the severity and extent of the disease. Transcutaneous oxygen tension, that is TCPO2, reflects the metabolic state of the target tissues. In this, a small electrode with a central platinum cathode surrounded by a circular silver chloride anode is used. The oxygen diffusing to the surface of the skin is reduced at the cathode and to produce a current proportional to the partial pressure of oxygen within the sensor. The electrode has a heating element that raises the skin temperature to 45 degrees centigrade for optimal blood flow and diffusion of oxygen from vasodilation. rise in capillary partial pressure of oxygen, liquefaction of lipids in the stratum corneum, and a right shift of the oxyhemoglobin dissociation curve. One of the studies demonstrates that the value less than 40 millimeters of mercury represents about 24% increase in the in the risk of healing complication, but no study has validated the use of TCPO2 to determine the level of amputation required in patients in whom revascularization fails. TCPO2 is less reliable in patients in whom there is active infection, edema, callus, active smokers because of the effect of vasoactive effects of nicotine, in warm ambient environment because of the vasodilatory effects of heat, or in patients with autonomic neuropathy or vascular calcification, even in the absence of a peripheral vascular disease. The normal value of TCPO2 is more than 55 millimeters of mercury. For wound healing, you require at least 40, but when it is between 20 to 40, wound healing is considered to be not reliable. It is most helpful in evaluating disease cases with severe ischemia, particularly when you're determining the level of optimal level of amputation, but there is no study that validates this. It is relatively insensitive in mild to moderate degrees of peripheral arterial disease because oxygen supply to the skin is far greater than what is the demand. Therefore, oxygen hemoglobin dissociation curve does not change rapidly until the oxygen saturation drops to less than 80%. Therefore, capillary oxygen tension does not decrease until the flow is severely restricted or oxygen demands equals or exceeds the supply. Hence, if the TCPO2 value is 0, that does not mean that there is no oxygen supply to the tissue in that area. It only means that whatever oxygen is supplied is already consumed and there is nothing left to reach the probe. Factors affecting TCPO2 include dependency, that is, it increases in a sitting or standing position, related to the increased hydrostatic pressure that dilates the capillaries and resistance vessels, thereby increasing flow. This phenomenon may explain why there is relief of rest pain in dependency. It is affected by exercise, that is, decrease in the skin TCPO2 because of shunting of blood away from the foot by dilatation of the intramuscular vessels. Age-wise, it is higher for younger age. In position, it is higher for more proximal position than distally. It is affected by skin and body temperature. It is affected by edema, obesity, and hyperkeratosis. Coming to laser Doppler and skin perfusion pressure. Laser Doppler uses monochromatic light to detect the motion of RBCs to a depth of approximately 1.5 mm into the skin. The actual depth depends on the power of the laser beam and the thickness of the epidermis and skin pigmentation. Light is backscattered by the tissue after transmission and again after it is reflected back to the receiving system. It is as a result, the frequency shifts are a composite of multiple vessels with multiple velocities and multiple angles. The output measured in millivolts is approximately proportional to the average blood flow in a 1.5 millimeter cube volume of the skin, lying 0.8 to 1.5 millimeters below the surface of the skin. The resting values are highest in the great toe and lowest in the proximal part of the leg. Peripheral arterial disease causes attenuation of the waveform, a reduction in velocity, and a loss of vasomotor waves. Laser Doppler can also can be used with blood pressure cuffs to measure the skin perfusion pressure. The probe can be placed slightly distal as the flow detector in the for similar results in obtaining segmental pressures or beneath the cuff, which is then inflated. The pressure at which the blood flow returns is noted as the cuff is slowly deflated. Normal pressure is between 50 to 70 millimeters of mercury and are decreased to 10 to 20 millimeters of mercury in patients with significant PAD. Pressure less than 30 is predictive of critical limb ischemia. A combination of skin perfusion greater than 40 millimeters of mercury and toe blood pressure greater than 30 millimeters of mercury has been associated with successful lower extremity wound healing. Finally, coming to the arterial duplex scan, it was introduced by Dr. Strandness in 1974. A duplex is non-invasive, cost-effective, suitable for serial examination, and permits identification of a disease. It reveals the natural history, progression, regression, and response to intervention of a disease. Doppler ultrasound system uses transducers fabricated from piezoelectric crystals to convert electrical activity to mechanical energy, that is ultrasound, and vice versa, thereby allowing the same system to transmit and receive ultrasound signals to and from the patient to produce images of tissue anatomy as well as characterize the blood flow. It allows tissue imaging at a depth of less than 1 centimeter to more than 20 centimeter. Doppler duplex imaging techniques include B mode imaging, that is brightness mode imaging, color Doppler, and power Doppler. The B mode imaging, the grayscale pixels reflecting the amplitude and position of returning ultrasound echoes is seen by processing up to 200 or more separate ultrasound beam signals that are retrieved by the transducer array. The scan converter then organizes these horizontal and vertical pixels to yield a two-dimensional image of the tissue being scanned. In a B mode imaging, the transducer should be held at right angle to the area being imaged, as you can see on the left, to give more distinct echoes. If, like as shown on the right, if it is held in a non-perpendicular angle, it gives a poorly defined wall structure and hence a poor imaging. The types of Doppler ultrasound display are color flow Doppler image and a spectral flow image. Color flow Doppler image shows the flow velocity distribution over a wide area displayed as color encoded map superimposed in a grayscale B mode tissue imaging. It provides semi-quantitative information on the distribution of the velocities over the entire region. A spectral Doppler image shows the time-varying flow velocity distribution at a selected sample volume, and it provides a quantitative information on the peak velocity within the sample volume. Coming to color Doppler imaging, it refers to pixel encoding of the blood flow based on a color bar that depicts both flow direction towards and away from the transducer and a mean velocity. To set the color gain correctly, the examiner should increase the gain until a noise speckle appears within the flow region and then reduce it slightly. This technique will optimize the display of a weak or a lower velocity blood flow signal, such as those adjacent to the artery wall. Excessive color gain causes color-coded flow pixels to bleed into or beyond the arterial wall, thus making the flow lumen appear larger than it is in the reality. The arterial stenosis is recognized by color Doppler imaging as reduction in the color encoded flow lumen, imaging of a high velocity flow region with a color bar aliasing, and a development of a mosaic flow pattern in the lumen. All three of these signify a turbulent blood flow. At the site of a high-grade stenosis, that is a more than 75% diameter reduction, real-time color Doppler flow will appear as a whitened, color desaturated flow jet with mosaic color flow extending for several vessel diameters downstream, corresponding to a post-stenotic turbulence. As you can see in this image, the top image shows a color aliasing occurring at the stenosis when the mean flow greater than 28 centimeter per second and extends to several vessel diameters downstream this area and below. The velocity spectra recording at the stenosis, that is the flow jet, indicates the peak velocity of 426 centimeter per second and the spectral broadening of highly disturbed or turbulent flow. This is the spectral widening of the flow. A power Doppler imaging displays blood flow. The display of the blood flow here is based on the amplitude of the backscattered Doppler signal. It increases the sensitivity of the flow detection 3 to 5 times with respect to the color Doppler imaging. This imaging mode is termed as color angio and is used by technologists for imaging of small diameter vessels, detection of flow, assessment of residual lumen diameter at stenosis, and detection of tricular flow associated with a high-grade stenosis. Flow direction is not evident with power Doppler imaging, and a flow signal is less dependent on the Doppler angle. Interpretation of Doppler imaging. A pulsed Doppler interrogation at the level of the stenosis reveals a PSV double than that of the velocity in the proximal segment. There is a spectral broadening and a forward flow throughout the cardiac cycle in severe stenosis. An occlusion is present when there is no flow within an arterial segment. High resistance waveforms are present in the artery proximal to the occlusion if there is no collateral vessel. Continuous forward diastolic flow is present in the proximal artery if a dilated high capacitance collateral is present. The artery that constitutes distal to the high grade stenosis will have a characteristic post-stenotic parvus et tardis waveform. Diagnostic criteria for a peripheral arterial diameter reduction are: when it is normal, there is no diameter reduction, the waveform will be triphasic, there will be no spectral broadening, and the ratio of PSV distal and proximal to the stenosis will show no change. In mild peripheral arterial disease, there will be a 1 to 19% diameter reduction with still having a triphasic waveform, but a mild spectral broadening and a PSV ratio, that is a velocity ratio of less than 2:1. In moderate peripheral arterial disease, the diameter reduction is about 20 to 49% with a biphasic waveform with a spectral broadening, and still the velocity ratio will be less than 2:1. In severe peripheral arterial disease, that is a diameter reduction of 50 to 99%, the waveform will become monophasic. There'll be a spectral broadening, and the velocity ratio will be more than 2:1. When the ratio is more than 4:1, it suggests of more than 75% stenosis, and a ratio of more than 7:1 suggests more than 90% stenosis. Doppler indices are PSV, which is the peak systolic velocity. It corresponds to the to each tall peak in the spectrum window. The ratio of PSV, that is velocity ratio across stenosis, asserts the degree of the stenosis. Velocity ratio means the peak systolic velocity at the stenosis and distal to the stenosis. When the velocity ratio is more than 2, it suggests more than 50% stenosis, and more than 4 suggests more than 70% stenosis. Pulsatility index is a ratio peak systolic velocity minus end diastolic velocity divided by the mean velocity. Normally it is more than 4 for peripheral arteries, more than 6 for femoral, and more than 8 for popliteal arteries. Damping effect is distal artery pulsatility index divided by the proximal artery pulsatility index. While normal is more than 0.9, a less than 0.9 ratio is suggestive of an occlusive disease. Resistance index is PSV minus EDV divided by PSV. Normally, it should be less than 0.7. Anything more than or equal to 0.85 is suggestive of increased vascular bed resistance and decreased end organ perfusion. Duplex classification of a peripheral arterial occlusive disease, same as what I had shown before. Normally, the peak systolic velocity should be less than 150 with a velocity ratio less than 1.5 and a triphasic normal PSV. In a 30 to 49% stenosis, the PSV becomes 150 to 200 and a velocity ratio is 1.5 to 2. 50 to 75% stenosis gives a peak systolic velocity of 200 to 400 centimeter per second, and a velocity ratio is between 2 to 4. More than 75% stenosis gives more than 400 peak systolic velocity, more than 4 velocity ratio with a dampened monophasic waveform. In a complete occlusion, there is no flow, and the length of the occlusion is estimated by the distance from the exit to the re-entry of the collaterals. Coming to renal artery imaging, this is based on the maximum PSV obtained from the aorta above the renal artery origin, that is at the level of the SMA approximately, and the renal artery itself. A normal renal artery PSV is 80 plus or minus 20 centimeter per second. RAR, that is renal to aortic PSV ratio, is less than 3.5. Normal renal artery waveform is biphasic, and it is a low resistance waveform with a RI of less than 0.8. Mesenteric artery imaging, when in a SMA or a celiac, when the PSV is more than 275 in SMA or 200 in celiac, they are indicators of more than 70% stenosis. Graft surveillance. Graft surveillance is done for a vein graft, and we do a baseline at 30 days, followed by a 3-month, 6-month, and yearly thereafter. Low velocities indicate poor arterial inflow, proximal stenosis, or large graft diameter. A presence of a parvus tardis waveform indicates inflow disease or a proximal stenosis. A PSV in the graft less than or equal to 45 centimeter per second is suggestive of a subsequent graft failure is likely to occur. A fundamental criteria for ultrasound evaluation of a bypass graft include a PSV greater than 180 centimeter per second or a PSV ratio greater than 2 indicates a 50% stenosis. Low flow states, again the PSV of 45 or less indicates increased propensity for graft failure, and changes in the waveform shape or velocity, shape and velocity measurement on serial examination warrants a close follow-up or a possible revision of the bypass graft. Advantages of a duplex scan are that it is easily available, non-invasive, no contrast use, no radiation use, cost-effective, and suitable for serial examinations. Disadvantages are that it is operator dependent. It may have artifacts due to shadowing from the overlying vessel calcification. There may be refraction artifact and affected by gender and physiological conditions. Coming to transcranial Doppler. Transcranial Doppler mostly uses 2 to 5 megahertz pulse range gated Doppler devices. There are 4 main ultrasound approaches for transcranial Doppler. Maybe transtemporal, orbital, transoccipital, or submandibular. Most commonly, we use a transtemporal, which is used to evaluate the middle, posterior, and anterior cerebral artery circulation and terminal internal carotid artery circulation. It is used to detect the cerebral artery stenosis. It is used for monitoring during carotid artery stenting, carotid endarterectomy, and thrombolysis to monitor for high intensity transient signals. It is also used for assessing cerebral perfusion. Coming to the advanced techniques, contrast enhanced ultrasound. The principle is administration of IV contrast agents containing microbubbles of perfluorocarbons or nitrogen gas. The microbubble contrast agent consists of a gas core, an external shell typically composed of albumin, galactose, lipid, or polymers. The microbubbles have a high degree of ecogenicity and act as nearly perfect intravascular reflectors for acoustic ultrasound energy without any local disruption. IVIS is again one of the latest ultrasound imaging. IVIS is intravascular ultrasound guided treatment. IVIS guided treatment is considered to be having a superior yield when compared to angiography only guided therapy. The real-time 360-degree vessel anatomy and morphology can be seen with an IVIS, and it is used in precise imaging of the vessel size and plaque morphology. It is used in detection of intimal flap and dissection. It guides interventional procedure, including stent sizing. It assesses residual narrowing, stent apposition, and expansion. It detects intraluminal webs, mass lesions, residual thrombus, and extraluminal compression. Comparisons of methods of non-invasive testing in patients with CLTI. And ABI, it is simple, inexpensive, quick, widely applicable, and it provides data to predict wound healing, limb survival, and is useful in monitoring efficacy of a therapeutic intervention. But its limitations are that it because of in compressible tibial arteries, it may give falsely elevated or normal values in patients with diabetes, renal insufficiency, or advanced stage. It also does not provide localization of the disease. Toe pressure or TBI is again simple and inexpensive and is useful in small vessel disease. Also useful in non-compressible tibial arteries. It provides data to predict wound healing and limb survival and is useful to monitor efficacy of therapeutic intervention. But it is limitations are it generally requires the hallux, as in the toe, to measure a TBI or a toe pressure. Hence, it cannot be used in patients with toe amputations or transmetatarsal amputations. Also, it does not provide localization of the disease. Segmental pressures are useful in initial anatomic localization of CLTI. It is useful in creating a therapeutic plan based on disease localization. It provides data to predict wound healing and limb survival. It is useful to monitor efficacy of therapeutic intervention, but it is not accurate in non-compressible tibial vessels, that is highly calcified vessels, as in diabetes, CKD patients, or in advanced age. TCPO2 is useful in assessing microcirculation. Again, it can predict wound healing and may be useful in monitoring efficacy of revascularization, but it has limited accuracy in the presence of edema or infection, which most of our patients usually have. It requires a skin heating to more than or equal to 40 degrees centigrade. It is time consuming and there is limited data validation. Skin perfusion pressure is useful to assess microcirculation and wound healing potential. It may be useful in monitoring efficacy of revascularization, and it can be measured in a shorter time compared to TCPO2. But again, its limitations are there is limited validation, and the probe size and shape may affect its measurement. This is summarizing all the non-invasive vascular imaging and arterial Doppler. Thank you. And that's the end of my presentation.
Thank you, Dr. Pranjal. Hello.
Yes, sir, I can hear you.
Excellent presentation as well.
Thank you.
We covered almost everything. Very detailed presentation. The topic is basically physiology as well as arterial evaluation Doppler.
Yes, sir.
Topic,
physiological assessment and.
Oh, fine.
Yes.
So basically, we have covered almost everything. That's what we try to get back, right? So some aspects which we need to address is if you add on to your presentation, like what is the normal flow through the blood vessels? What is the type of flow you get in the blood, laminar flow, things like that.
Sir, your voice is breaking. I'm not understanding.
Yeah, a little bit of physiology would have been little more added to your content, like what is the normal flow, what is the laminar flow, and when do you get turbulence, and what is shear stress, and these are the things, other things that usually will be part of your examination also, and where the shear intimal hyperplasia occur during an anastomotic side, right? And what are the flow dividers, particularly in relation to carotid bifurcation? This aspect should also be covered in otherwise that aspect is another thing you have mentioned about cos theta in the Doppler equation, right?
Sorry, theta. Sir. Yes, sir. Yes, sir.
Cos theta. Yes.
Yes, sir.
So why do you are not supposed to hold that Doppler probe in a vertical angle, right?
Yes,
for
sir.
your
Yes, sir.
handle Doppler. Why?
Yes, sir.
Any idea?
Why you're not supposed to hold it in a?
The vertical, it's a 90 degrees angle to the examining part, right?
Yes, sir.
Yeah, I'll just tell you this because cos theta 90 is equal to 0, right?
Yes,
That
sir.
equation.
Yes, sir.
That's why you're not supposed to hold it at the right angle. That's as simple as
Yes, sir.
the interpretation of the property. Another is, see, most of the institutions, like you probably will be having your